So good evening, everyone. I'm Brenda Goldfarb. I'm the Adult Programming and Outreach Coordinator here at the Cornwall Public Library. And we are absolutely delighted to have Dr. Ashraf again with us for another talk. He gave a very good talk in May, and we welcome you back with open arms. People are still raving about the last one, so we know this one will be wonderful too. Thank you very much. And we really thank our partners, the Montefiore St. Luke's Cornwall Hospital, for working with us and partnering with us to bring wonderful information to the community. So we're pleased to have the institution working with us and here with us. So with that being said, Dr. Ashraf, after graduating summa cum laude with a degree in biology from the New York Institute of Technology in Old Westbury, New York, Dr. Ashraf went on to receive his medical degree from the New York College of Osteopathic Medicine, also in Old Westbury. He trained in orthopedic surgery at North Shore University Hospital in Plainview, New York, and recently completed a sports medicine fellowship at the Houston Foundation in Columbus, Georgia. Before becoming a surgeon, Dr. Ashraf was a licensed emergency medical technician who worked as a volunteer and participated in community education programs. So doing programs like this is no stranger to you, Dr. Ashraf, and we thank you. He has a passion for sports medicine and research. He has provided team coverage for football teams, and I believe I read a hockey team as well. Dr. Ashraf is currently board certified in orthopedic surgery. He is a member of the American Orthopedic Surgery of Sports Medicine and the American Osteopathic Academy of Orthopedics, as well as Arthroscopy Association of North America. And he currently serves as the medical director of sports medicine at Montefiore St. Luke's, Cornwall. And tonight we are pleased to have him here with us, providing a talk on orthopedics, of course. So Dr. Ashraf, it's all yours.
Great. I hope all you can hear me. Thank you again for the kind words. It's nice to have a small crowd, via Zoom. When it comes down to questions, this is a good time to we can get some really specific questions and hone down on any certain topics that we get to. I'm just going to wait for our slides to open up. We have to go back to our first slide. Sorry, the screen is I can't see you guys. So if you have any questions, please let me know if I'm not speaking loud enough. So today's topic is really common sports injuries in the knee and shoulders. I kind of kept it broad. Kind of where I did my residency, grew up is in Long Island playing multiple sports, and now did my fellowship down in Georgia about 10 years ago, and now been up here since. Knee injuries, as orthopedic surgeons, we just don't do surgeries all the time. We know most of what we do are take care of patients that are active, have a fall, and is usually managed non-operatively. For the knee injuries, I wanted to focus on meniscus, ACL tear. Patellafemoral pain is pain underneath the kneecap, which is a very common issue people have as they kind of get back into activities. I've seen an uptick of this, especially post-COVID, as patients have not been as active, and now they're trying to be more active with the summer, and now they have this generalized knee pain, as well as iliotibial band syndrome, which is a way of saying runner's knee. Shoulder injuries, we'll focus on shoulder dislocations, shoulders popping out of the joint. AC separation, which is another injury a lot of football players get, or from a fall, where you disrupt the acromioclavicular joint. A lesion that's called a SLAP lesion, which is the long is superior labrum, that's torn from the anterior to the posterior, and it's a very common shoulder injury in throwers or lifters, and the dreaded rotator cuff tear. Little thing about knee anatomy, very important. Knee, you have a bone here that's called the femur bone. You have a bone here that's called the tibia bone. And in between the two bones, you have this nice layer of cartilage, as well as ligaments such as your anterior cruciate ligament, posterior cruciate ligament, meniscus, which is this disc-shaped organ. You have two of them. You have one on the outside of your body, and then you have one on the medial, which is on the inside. So knee injuries are pretty complex, but the most common injuries we see are meniscus tears, ACL tears, as well as cartilage issues underneath the kneecap. Meniscus can tear in multiple ways. You know, the very common thing we get is either someone who has severe arthritis and then comes in and says, you know, my MRI shows a meniscus tear. And, you know, the meniscus is torn, but the big issue at that point may be the fact that it's more arthritis than a meniscus. Meniscus tears are most common symptoms are locking, catching, and the most common way people describe how they hurt it is a twisting mechanism. They're in place, their body moves, but their knee doesn't, and they feel something tear. Pain doesn't go away. They try therapy, and with an MRI, we're able to catch this meniscus tear. Several different types of a meniscus. There's so many different ways a meniscus can tear. You can have a longitudinal tear, which is torn but doesn't come into one of the areas. You have a beak tear, where this piece may be flipping back and forth into the joint. That can cause pain. This is one that I did 2 of these repairs on Monday. Basketball players, 116, 120. And when this happens, the knee is locked, and you have to take this piece that's torn and reattach to where it came from. A tear like this, you're really gonna have a hard time repairing this, so we tend to go in and clean this area up. And people say, oh, I had my knee cleaned up. That's what they mean. Best way to see a meniscus is on an MRI, and MRIs are ways you can't see a meniscus tear on X-ray. And on MRIs, you can see this line through the meniscus, and that's how we know that a meniscus is torn. And there's another line over there. You can see this white line that kind of goes from here all the way across. While on the outside meniscus, you can see it's a triangle, and it looks, that white line does not go up on top or on the bottom, while this kind of goes all the way across. But one thing is very important to know, that not all meniscus tears need surgery, only ones that hurt. If we get an MRI on a bunch of people over the age of 40, a good majority of them will have a meniscus tear that is what we call incidental. We know it's there, but doesn't cause any pain, so we don't get too excited about that. Preferably, if it's repairable, this is a picture of the meniscus. So this is, again, the tibia, and that's the meniscus. We want to go in there and put some stitches and hold that together, like we talked about in the bucket handle. And you can see there's all these nice little stitches that you could put across to hold that meniscus together. But while other times you have a tear here where you go in with the biter or a shaver and you just clean the area out, take out the part that's torn. It's very hard to repair. Over the age of 25, it's very difficult for the meniscus to heal, meaning you could put all these stitches into the meniscus, but you may not have healing that happens in the meniscus. Most common treatment is rest, ice. You know, if you're doing squats, stop doing squats, activity modification. And other times, surgery is the answer, which is a repair or a way of cleaning up the meniscus. This is a video of, you know, what I want to show is how tight the space is. You know, you really don't have a lot of space to work with, but what we are able to do, and we offer this at St. Luke's Cornwall, is be able to fix these meniscus tears in a really cool way. So you can see we're first cleaning this area up for repair. We want to create some bleeding, and that's a probe that we use to create some bleeding into that area. I'm not sure if it's portraying well. So now we're using a meniscus repair kit. These are disposable meniscus kits where it actually helps us put a suture in very tight places. So that's one suture that we just placed there. And we're about to place another suture. And you'll see once we do that, we just pull on one strand and it'll bring the meniscus together. I know the videos are a little choppy. I think We don't have great internet right now, but I hope you guys can see this. So now that one strand, we just pull on it and it'll actually fix the meniscus. And that's called an all inside suture technique. In the past, they used to repair the meniscus with a big cut, and no longer do they have to do that. You know, we can fix this with all arthroscopic techniques. Anterior cruciate ligament, very common injury from twisting, basketball, sports, weekend warriors, falls. We can get an ACL tear. You hear this on ESPN a lot. Twisting, pivoting, sudden stop. And the biggest sign or symptom is swelling and instability. And over time, some people say, oh, my knee is giving out. It doesn't feel stable. Anterior cruciate ligament is a large ligament, gives us a lot of stability. And when it's torn, it can cause a lot of instability in the knee. Treatment, mostly non-surgical, activity modification, rehab, bracing, and that tends to be in more of our less active crowd. A lot of patients, they have a fall, but they say, listen, I have no pain, no instability, and I really don't, do a lot of sports. You could treat them non-surgically. Most of our younger patients, we tend to be a little bit more aggressive in doing surgery on these ligaments. That's because if you leave the ACL alone, there are studies that show you put more pressure on the surrounding ligaments, such as the meniscus and cartilage. So you can't get arthritis sooner if you don't do anything to the ACL. So if a 17-year-old injures their ACL, more than not, we're aggressive in reconstructing the ligament. So why do I say reconstructing and not repair? The tendon, you can't suture together because it's like suturing two ends of a mouth. And that's why we reconstruct it. And this is an example of a reconstruction. This is, a tendon that we made, and we pinned it here with a little plate, and we pinned it here with a little plate. And it is actually one whole tendon, either from the own person, the person called an autograft, or from a cadaver called an allograft. And there's several ways we could fix the ACL. And so one way we do at St. Luke's is fixing the ACL with minimal drilling, minimally invasive, leading to less pain, less opioids, and a faster recovery. And so this is a video of just kind of looking arthroscopically where the old ACL was. And then now we use these guides and we drill into this area. But this drill is kind of fun. This drill, as you see in the bottom left, has a little fin, and I can decide how big I want the socket, 6 millimeter to up to 12 millimeters. So that fin I can deploy any way I want. And then once that pin deploys, I actually, instead of drilling, pushing forward, I pull back. And when you pull back, you're able to make a socket very precisely with a very small incision. And you can see this is the drill. Again, I activated the fin, and you'll see I will start firing it and pulling it backwards. And that's how we make a reverse socket. Same things we could do in our homes, in carpentry, we could do in our knee with a very minimally invasive procedure. Once we have made our two sockets, here's the femur socket, here's the tibial socket, we're able to take a graft and shuttle it. So that's the one socket we made in our femur where the new ACL will go. And that wire helps us shuttle our repair device. That's the button that we saw in a schematic prior. And that button will actually work its way through that hole and flip on the other side, allowing an area of fixation. And there it goes, it flipped. So now it can't come back through that tunnel anymore. And once that has flipped, we can now shuttle our new ACL graft right into the socket. And that's it. And now you have one area that's fixed, which is the femur. And then on the tibia, we're able to fix that as well. Sorry if this is a little bloody for some of our audience members. So now this is the tibia, and we have a measurement device that gives us exactly how much pressure we want or tension we want that ACL to have. And then we put it on a screw right into the tibia. And all is done through pretty minimally invasive approach and very scientific to get the exact pressure and tension you need. So ACL obviously is one of my favorite surgeries to do. It's very rewarding. Patients tend to do really well. But once again, there is nothing that's 100%. It takes about a year for our athletes to get back to sports physically, but mentally, psychosocially, it takes almost a year and a half till they start feeling like themselves. Patellafemoral syndrome, something that, as we talked about, very common conditions. This happens to gymnasts, runners, active patients, not so active patients, obese patients, or patients that are starting to walk again or doing activities. And most of the complaints are, after sitting for a while, standing the first couple of steps, then stairs, squatting, jumping, and the pain could be so severe, it feels like the leg's gonna give out on you. And the reason for that is it's the patella, and the patella is connected to a muscle called the quadriceps. So sometimes you can have that feeling when there's significant pain. The patella is the cartilage you see up here, and that's the femur, where it looks like this patella will sit. It's kind of made for that. But if the patella cartilage gets shredded, and in orthopedics, we describe a lot of cartilage issues by using meat analogy. So we call this crab meat. So when we start seeing crab meat like cartilage damage, we know when this person walks and this touches this, they're gonna have significant pain. And sometimes it's that they have arthritis under the kneecap. Other times, the patella isn't tracking right. And really the best way to treat that is physical therapy, home exercises, and bracing. Really, non-surgical is the way to go for patellafemoral syndrome. You could use a brace like this, which helps with better patella tracking. You could use KT taping, which a lot of physical therapists use to improve patella tracking. Injections, cortisone, I'm not a big fan of, but overall, it's really non-surgical. The reason why surgery is not recommended is because there's really not too many great options with great successful outcomes. If your arthritis under the kneecap is really bad, then a partial replacement works well. But most of the time, it's not bad. It's with certain activities and really home exercises, strengthening of the quad, hamstring, core will take care of most of these. Another thing that we're seeing more of is people, again, are back to the gyms, back to running, but they're just slightly deconditioned. So it's caused by the iliotibial band syndrome. It's a band of tissue that comes from up in the hip and goes all the way down to the knee towards an area called the Gerdy's tubercle, which is around the knee. Most common complaint is sometimes your hip can hurt, but other times the pain is more on the outside part of the knee. Worse with running, not usually while you're running, it's after you run that the pain tends to be. Swelling, not as much, but the real issue is this IT band. The IT band, like anything else, can get tight. And when it gets tight, it causes pain right on the outside of the knee. Treatment is a foam roller, which is probably one of my favorite home gym equipment. You get a foam roller. If anything really hurts, you're able to stretch your hamstring, quadriceps, really any muscles you have in your body. Stretching, activity modification. Activity modification is tough because when I tell my runners not to run, they look at me like I'm crazy. So you have to figure out how to let and allow our patients to continue things they want to do, things they love, things that make them happy without hurting themselves more. So we usually come to an understanding that, okay, spend an extra 10 minutes before you run with stretching, and then stretch more after. Try some anti-inflammatory, try some heat. And so as long as we can keep you guys doing what you want to do, I think that's the essence of sports medicine. Shoulder injuries, I know we kind of touched on some high level stuff on knee injuries. Shoulder injuries is very difficult because shoulders, you have so much motion, you know, you can do so much with your shoulders, but if any one of those range of motions are limited, it vastly affects your quality of life. My female patients, when they can't turn their arm back, they can't get to their bra strap. My male patients, they can't get their arm to get their wallet or anything in their back. That's a motion that we really take for granted in the shoulder. Overhead motion, brushing your hair, getting things from the cupboard, all these things can be affected with shoulder injuries. Shoulder anatomy, it's a very complex anatomy, actually. You know, just to call it a ball and socket joint would be doing it injustice. But overall, you have a socket that's called the glenoid, and then you have a ball here that's called the humerus. And the ball and socket joint should be lined up. But outside the bone, you have several other soft tissue. The other joint that we have is another small joint up top that's called the AC joint. So in reality, there are two joints in the shoulder. There's a acromioclavicular joint, which is the joint you could feel on top of your shoulder, which is something when people say, I separated my shoulder in high school, that's what they're talking about. And then you have the glenohumeral joint, the ball and socket joint, which is the big joint. And when you pop that out of place, that's called a dislocation. Inside the socket, so imagine you're looking at the socket, there is a cartilage rim that goes all the way around to give the socket a little bit of suction. The socket is very shallow. So if it's so shallow, you need a little like a suction cup to keep that ball into place. And that's your labrum. And you could tear that labrum up top, and that's called a superior labrum tear. That tears all the way on top. And that can cause pain down the biceps, can cause pain throwing, pushing, push-ups, shoulder exercises, again, a very common injury. Your rotator cuff is a group of muscles, 4 of them, that come over the shoulder and attach to your humerus. And that's the supraspinatus, infraspinatus, subscapularis, teres, and that's what helps with a lot of your strength in the shoulder. Most common complaint when I hear nighttime pain in the shoulder or I can't sleep because of my shoulder, I think about a rotator cuff tear. So shoulder dislocations, again, very traumatic. You could happen from a fall, electrocution, sports injuries. And when they pop out of place, you can see just from this x-ray, that's the socket, and that ball is completely out of the socket. But as the shoulder dislocates, it causes a lot of damage. And most common damage it does is it tears the cartilage that's in the front of the shoulder, and that's called the Bankart lesion. And once this happens, it predisposes the shoulder to keep dislocating. I work with one of my partners, Dr. Yehorchuk, who was the orthopedic chief surgeon at West Point, and they did a really great study, and they looked at, these cadets who are very active. When they dislocate their shoulder, what happens if you don't fix them? What happens if you fix them? And what they found was if you don't fix them, they dislocate at a tremendously higher rate. So at West Point, you need to dislocate one time, and they're going to go fix your labrum because they know in this population of active individuals, once they dislocate, they tend to be a little bit more active and more likelihood to dislocate. So treatment is, acute immobilization, rest, ice. If someone's a little bit less active, older, they have a lot of arthritis, I tend to be non-surgical with this. Surgical is really arthroscopic or open. We tend to do things arthroscopically now with the camera. And imagine this is a labrum that was broken. We put anchor here, and anchor here, passed our stitches all arthroscopically with 3 little holes, and able to repair this as opposed to an open incision. And we're able to do this with like a 25-minute surgery, but the recovery is significantly longer. But again, younger individuals, we tend to be a little bit more aggressive. Older individuals, we can watch, and if it's not better or they still have what we call apprehension, which is if you take a shoulder in this position, they fight you because they feel like their shoulder is going to pop out and they don't want to get there. And it's a body's way of protecting itself. And if they still have apprehension, that's another reason why you can go in and repair this. AC joint separation. We talked about the acromioclavicular joint. The most common is falling onto the shoulder or someone tackling someone with their shoulder. And you can see in this schematic where this joint, this clavicle is sitting significantly higher than this acromion. And the reason why that happens isn't that something broke, but it's all these ligaments that stabilize that joint have ripped. Most of the time, like, you know, if the acromion and the clavicle are in the same ballpark, most of us would let this heal and say you may get some arthritis in that joint. The only time we tend to be a little bit more aggressive with AC joint separations are individuals that throw, pitchers, football players, basketball players, or if the two bones are so far apart that that's more than 300% displaced, we tend to be a little bit more aggressive and repair it. The way we repair this, you know, it's again arthroscopically or open, and I've shown you this button configuration for ACL. And so we do the same type of thing. We put a button underneath what we call the coracoid. We put a button up here, a button up here, and we use the stitches and we really just pull on it and it brings it together, like zip line it all the way down. And that holds the pressure in the AC joint and aligns this together. Again, non-surgical for most, surgical for grade 4, grade 6, which is highly, highly, highly displaced. Labrum, superior labrum tears and biceps tears, they kind of go hand in hand. You know, a lot of times we see this on patients that are doing a lot of CrossFit or that type of exercises, and they feel significant pain, like their arm just dropped, like a drop arm. And they have significant pain, not improving. They've done home exercises, and then you get an MRI and you see this labrum tear, which is right over there. And this is a labrum tear that's been fixed arthroscopically with a few stitches. And you can see the biceps attaches right near the tear. And that's why a lot of people will have pain radiating down towards the elbow, towards their biceps. Talking about biceps, you can also rupture your biceps. This is something that we see often. You can see the difference between this biceps and that biceps. Some may say this looks bigger, but in truth, this is called a Popeye's deformity. When someone does something, they feel a pop and they actually rupture their biceps from they ruptured this tendon from this attachment. And that leads to this view called a Popeye's deformity. Again, if it's a non-dominant hand, someone who's a righty, this happens to a left hand, they're a little bigger, a little healthier, where you can't really see the deformity like you see in this gentleman, you can not fix it. You do lose a little bit of strength, and you know it's not going to be this strength that you lose. You're going to lose strength, what we call supination, like opening a jar. You'll be a little weaker. You can get a little bit more muscle cramps, but overall they do really well. Someone again who's active, skinny, doesn't want that deformity to be seen, we tend to repair these with a screw in the groove of the biceps. So you see the biceps was attached here, it ruptured here. We make a cut and we reattach it. So the biceps is now pulling where it ripped from. So we tend to just repair it down in the groove. And that restores the length of the biceps as well as the strength. But it is a surgery. Again, for more younger active patients, we can, but I have repaired biceps for 70-year-olds that are super active, and you know, you catch them early, you can repair them early. The only thing I will say is a lot of times in our patients over the age of 40, when they rupture their biceps, they tend to injure their rotator cuff as well. And this is a great picture of a rotator cuff. This is a tendon that's coming over and attaching right across the shoulder. And you can get a rotator cuff tear with a biceps rupture. Treatment, we talked about repair, release, non-surgical. It really matters when they present to you in the office, what they do, what they want to get back to. If someone says, you know, I really am not super active, this was a freak accident, leave it alone and they should do fine. Impingement syndrome is a very common thing we have in our shoulder. It's basically a bone spur that forms underneath the acromion. And that bone spur in certain motions will actually push on the rotator cuff, leading to a rotator cuff tear. We call that, when we repair this and take the bone spur down, we call it a decompression. Most of the times we'll start off with a little anti-inflammatory, cortisone injection, physical therapy, and if not better, we tend to get an MRI to see how bad the bone spur is and if there is an associated rotator cuff tear with it. So in truth, rotator cuff tears is a continuum from impingement, which is early rubbing on that rotator cuff, to partial tear to a full tear. And mechanism of rotator cuff tear really falls onto two groups. An acute tear, someone who say falls or tries to catch something and they feel this pop in their shoulder, and after the pop, they're not able to raise up their arm. You get an MRI, they tend to completely tore the rotator cuff acutely, and that needs to be fixed sooner than later. Chronic tears are tears that happen over time. You tear 5% every year, and then the pain becomes so bad, you get an MRI, and you find out that this rotator cuff is completely torn, and it's so pulled back that sometimes we're not able to fix it. So pain sleeping is a big thing that triggers me to think about rotator cuff. Obviously, weakness on physical exam when I push and test the rotator cuff. And pain reaching overhead, that to me is more impingement. But it's a story. You see how the shoulder examines. You see where their pain is. You listen to patients, talk about when they have pain. And if they say, oh man, at nighttime it's the worst, I can't get to sleep, and then you start thinking, hey, this may be a rotator cuff that's been ruined for a while. Treatments for rotator cuffs are kind of fun. They should do this open, and some still do mini open, but most of us are doing this arthroscopically. And a lot of these anchors that you see here, you may have seen in the Home Depot or Lowe's because they're very similar. You punch a hole for a 4-5 anchor and you put a 5-5 anchor in. These are usually biocomposite, meaning they're absorbed by the body and turned into bone. And these anchors are connected to these sutures, and we're able to pass all of this all arthroscopically through little holes and be able to repair something that was repaired in the past with a pretty big incision. So, the schematic, I hope you can see how it's on the left side, how it's kind of repaired. Through really slick instrumentation, we're able to pass all these sutures all over the rotator cuff, using a visualization system that really helps us look at all over the shoulder. There's really not one part of the shoulder you can't see with the camera. And the camera has angles, a 30 degree, a 70 degree, so even hard to see places you could see. It's hard to really understand what's going on here, but it's basically a rotator cuff. This tendon should be attached to here, but it's not. So with multiple techniques, they put anchors in and they brought this tendon over, and you can see the tendon is now down to bone. This is a video of a rotator cuff repair when it's done. So all this is done arthroscopically. So you're passing all these stitches, tying all these knots, putting these anchors in through 3 or 4 little holes. And it's all done under water, meaning we blow up the joint with some saline so we can better visualize. So this is a large tear that you can see. We have passed multiple stitches to get the tendon back down to bone. Steps, the steps are, we put an anchor into the bone, we visualize, and you can see the anchors here, and we then have to pass all these stitches through the rotator cuff. Once we do that, we make these little holes in the bone where the tendon is going to sit, because we want bone marrow. The bone marrow that we punch these little holes, the marrow comes up from the bone and brings the red blood cells, which will help the tendon well down to the bone. So it's just not mechanical healing, there's also a biological healing that we have to keep in mind. Again, the anchor, another anchor going in. Again, these are 5.5s with pretty good pitches, so it really captures the bone well.